Hello, everyone. A warm welcome to today's Module 2 of Indian Chess Society's certification course on sleep medicine. I'm so very happy that all of y'all have logged in huge numbers and y'all are supporting us wholeheartedly. This is an initiative by Indian Chess Society, and I'm so grateful to the entire governing body of Indian Chess Society for taking this initiative. To y'all, we bring today the best faculty we can get ever for today's module. We have absolutely who's who from our country who's practicing fabulous quality sleep medicine, and they will be sharing words of wisdom to us today, and they will make us become better clinicians. So, with this brief introduction, I would like to let you all know that today's module is on clinical manifestations and systemic manifestations of obstructive sleep apnea, which actually forms the basis of our practice in sleep medicine. I'm so grateful to SIPLA, especially Hitesh, for helping us drive this academic activity. With this brief introduction, I would like to call our today's champion speaker, none other than Dr. Murli Mohan. Dr. Murli requires absolutely no introduction whatsoever. Dr. Murli, as we know, he is currently the senior consultant and pulmonologist at the Narayani Health at Bangalore. He was earlier past president and HOD, B.R. Ambedkar Medical College, Bangalore. He has been immediate past chairman of API and also of the Karnataka chapter. He's got more than 100 papers, posters, and publications in national and international journals. He's the founder of Nightingale's Life Saving Services, which has trained over 90,000 persons in CPR in Karnataka. And this is just so overwhelming. And respect for you, Dr. Murli. I don't want to read other things because everybody really knows about him, but I want to say that he is a captain of pulmonary medicine. When it comes to sleep, he is absolutely unbeatable. He is absolutely amazing. And I want to say that he is the captain of pulmonary medicine.
So have we lost Dr. Amita?
Dr. Murli, a warm invitation to you.
Yeah, so I think, Amita, thank you so much for that lovely introduction and huge respect for you for the interest you take. People should know that she's coming from across the world, still logging in though she's on holiday. So you'll know she's never on holiday and ICS is a part of her everyday life. So thank you hugely for taking time off from a holiday to spend time with us. Without further ado, I'm going to emulate your example and start with the talk that I'm supposed to give today. This is on systemic manifestations of obstructive sleep apnea. Just give me a second while I get this going. Yeah. So I bring you greetings from Narayana Health in Bangalore, and a huge thanks to the ICS, the organizers of this sleep certification course, my colleagues here who are going to do a splendid job of explaining things to you. But let me start with the fact that we sleep for about a third of our lives. So that tells you it's a very, very important part of our lives that we're actually sleeping for 1/3 of the lives. We will not be wasting time unless there is an important function to it. We've also realized in the last 15 years or so how important life is, and it's difficult to get the cardiologists to accept that sleep is a very important part. So you see on the left, in 2010, the American Heart Association came out with something called Life Simple 7, emphasizing the importance of things like blood pressure control, sugar control, weight control, avoiding smoking, exercise. But you'll notice that in this left-hand column, sleep was not included. By 2022, they'd woken up to realize sleep's importance. And now you can see it's now called Life's Essential 8. And in addition to the initial 7, now sleep is included as an important part of being healthy. So what are the functions of sleep? You heard it in the last module, the importance of sleep and the functions it has. But just to recapitulate, it has a restorative function where it restores tissues, repairs tissues, and synthesizes proteins in greater amounts than during an active day. There's energy conservation, obviously. You can't be expending energy all the time. We know that sleep enhances immunity, and if a person has lack of sleep, their immune function drops off. We know it's very, very important during infancy and helps the brain mature. Sleep is extremely important, and this is to consolidate memory. And you can actually see thickening of the synapses between neurons during sleep. And this is particularly so as a baby is growing up, as a child is growing up, but is also important in adults. And that's something I always tell my students. You need to get a good night's sleep after you do the studying for exams. Otherwise, it's all going to get washed away and not consolidated. You also have brain plasticity, and that's why you'll find that as a kind of uh, repair part after a stroke, people tend to sleep long hours. It's partly due to the brain damage, but it's also protective because the neurons are trying to repair themselves and new neuronal connections are trying to form. And finally, we were taught when I was in medical college that the brain lacks a lymphatic system, but we now know that there's a glymphatic system, the equivalent of the lymphatic system in the brain, and that cleans out neurons during deep sleep, especially during REM sleep. You can see surges of this fluid coming and clearing out the tau protein and other proteins that accumulate and slow down neuronal function. So there are a lot of important functions of sleep. And obviously, if you don't have good sleep, these functions are affected. And poor sleep, quality-wise poor, quantity-wise poor, can affect these functions. So if we look at the natural history of obstructive sleep apnea that we spent a lot of time in the last module, we know that it actually starts at a much earlier stage than when we pick it up. So there is what is called the stage of susceptibility. And there you'll find that these people have craniofacial abnormalities, they have problems of ventilatory control, they have obesity genes, and you can see these actually quite early, and we don't pick up on it. It then moves into a stage of snoring and then pre-symptomatic disease. So practically everybody who has OSA at some point will report snoring. And strangely, I found that before we make a diagnosis, family members and patients will also always tell you that the snoring has actually come down recently. I have no idea why that is, but I keep hearing patients and families telling me that. Then there are the influences of epigenetics, the environment, the use of alcohol, smoking, and just a sedentary life. And we now say that sitting is the new smoking. So people who sit for a long time or use these substances have a bad environment affecting their lifestyle. Those are the ones you need to look out for and catch them before they move from a pre-symptomatic to a symptomatic phase. And through all this time, obesity is actually increasing. At this point, they have the stage of clinical disease and they present with morbidities. Apart from all the other things that we speak about, heart failure is extremely important, and the use of sleeping pills because they feel they have not slept, though actually that is poor quality sleep. And of course, unfortunately, all this leads to an early death. Unless you can treat them, catch them early, you catch them at the stage where they can recover, and hopefully you can reverse disability. And this is unfortunately where we make a diagnosis late and start therapy late. And if we started it early, hopefully we would make a difference to this natural history. We know that obstructive sleep apnea affects the quality of life. It affects both the mental and the physical domains. So this short form 36, a very, very useful health-related quality of life measure. If you look at it by obstructive sleep apnea status, and this is after controlling for all covariates, you'll find that the mental component, the physical components are both looked at here. The blue bars are the ones who have obstructive sleep apnea and excessive daytime sleepiness. And you can see that they have a significantly worse score on both the mental and the physical domains as compared to those who have obstructive sleep apnea but no excessive sleepiness, and those who have no obstructive sleep apnea. So clearly, the quality of life drops when a person has obstructive sleep apnea. And if you look at the common comorbidities, on the left, you see that several of the commonest conditions that we come across are associated with obstructive sleep apnea. Now, it's not often very clear whether sleep apnea is causing these problems. There are common risk factors, and possibly both operate in a person developing sleep apnea. But more and more over time, I'm convinced personally that sleep apnea is the starting of many of these problems, coupled with the genetic background and environmental influences. On the right, you see, the different comorbidities, again, from the same study, looking at OSA with excessive daytime sleepiness. Commoner in all these comorbidities, whether you're talking about depression or high BP or lipid abnormalities and GERD, some of the lung problems like asthma and COPD, atrial fibrillation, and I'll come back to all these soon. In all these, those who have OSA do worse than those without OSA, and those with OSA who have excessive daytime sleepiness do worse than those who do not exhibit this excessive daytime sleepiness. And these are some of the comorbidities that are commonly seen with OSA. The person has drug-resistant hypertension. There's an 83% probability that they have obstructive sleep apnea. And this goes all the way down to coronary artery disease. A third of patients almost with coronary artery disease have obstructive sleep apnea. And in between, you'll see atrial fibrillation, which I'll come back to soon. And it's not single comorbidities. This graph tells you that if a person has no or one comorbidity, that's in blue. If they have 2 to 3 comorbidities, it's in orange. And if they have more than 3, 4 or more comorbidities, it's in gray. And you can see that patients with OSA have significantly more multimorbidity than people who are just snorers or who have insomnia or who have restless leg syndrome. Multimorbidity is common if you have OSA. We tend to think of OSA as a single thing, but we know that there's a lot of heterogeneity. This was a study done in South America where they reported that they could identify 4 distinct clusters. I'm not going to go into this because this is more a part of the first module, but you can see on the bottom left that people fall into various different clusters, and each of these clusters has a different set of comorbidities. And you can see on the right the p-value telling you the differences between these are fairly significant, differs from cluster to cluster. So as we learn more about COPD, about OSA, we understand the phenotypes of OSA. We understand that they have different ways of presentation. We also recognize that they have different levels of comorbidity associated with each of these clusters. And these are some of the other clusters that go with it. And you can see that they differ in physical examination, in symptoms that they have, though there are some typical comorbidities. There are some typical symptoms and typical signs on physical examination cutting across the whole lot. This was a study we did several years ago. We presented it at the ERS, and you can see that almost 50% of patients with with OSA have diabetes. More than 50% have hypertension, and more than a third have both hypertension and diabetes put together. And there is a small increase if you look at those with pure OSA. And very strangely, you'll see that most of our patients, out of the patients that we had with moderate and severe OSA, 182, the majority, 169, had severe OSA. So severe OSA is what we are picking up, and we're not picking up enough of the mild to moderate OSA, the point at which one really needs to interfere. Let me move on to 2 main areas. There are just so many morbidities, I will not be able to cover it in 20 minutes, so I've decided to focus on 2 predominant groups, cardiovascular disease and metabolic abnormalities. So cardiovascular disease is closely associated with OSA. It arises from a mixture of anatomical factors, altered muscle tone. We know that there's variations in intrathoracic pressure when there is an obstruction and you're trying to breathe in. You're performing the Mullers and sucking a lot of blood inside. And then when the apnea is over, there's a sudden surge of blood. So this leads to a combination of sympathetic activation, overloading of the heart, and underloading at different times of both ventricles. We all know that there is hypoxia and hypercapnia in some patients. And of course, there's dysfunction of neurological control. And these lead to the consequences listed below: arrhythmias, heart failure, systemic hypertension, pulmonary hypertension, and coronary artery disease. But one thing that's not mentioned here is dilated cardiomyopathy, a part of heart failure. Apart from coronary artery disease leading to heart failure, is a very, very common presentation of patients with obstructive sleep apnea. And I've had patients who presented to me with pure OSA-related cardiomyopathy, ejection fraction of 30%, a young man, he was 30 years old at that stage, diagnosed he had sleep apnea, put him on treatment, and now his ejection fraction is between 50 and 55. Not normalized, but leading a completely normal life until, unfortunately, a few weeks ago, he had a stroke. And that's because he's not using his CPAP regularly. So, if you look at what is happening actually in obstructive sleep apnea, which leads to cardiovascular consequences, apart from the hypoxia and hypercapnia, there is sympathetic overactivity, there's endothelial dysfunction as a part of systemic inflammation, there is systemic inflammation causing direct damage to various organs, and there's metabolic dysfunction characterized by worsening insulin resistance, impaired glucose tolerance, impaired fasting glucose, dyslipidemias, and all these lead to the various morbidities, cardiovascular morbidities listed below. One of the things that's not mentioned here is the effect on platelet function apart from endothelial function. And we know that hypoxia induces platelet activating factor and makes the platelets more sticky. So that's the sequence of events moving from pathophysiology through a variety of disease mechanisms and ending up with the associated cardiovascular disease. And I'll call your attention to the last one, mortality increases. How does hypoxia cause problems? It works through the hypoxia inducible factor, working through various genes. And this is true whether you have continuous hypoxia or you have the intermittent hypoxia that we see in patients with obstructive sleep apnea. Not going to go into this, but this is a complicated pathway that works through oxygen deficit, causing induction of hypoxia-induced factors, which works on the nucleus and the genes and produces more of the pro-inflammatory factors that leads to the systemic inflammation in obstructive sleep apnea. Coming to hypertension, as I said, hypertension is one of the most common comorbidities of obstructive sleep apnea, and it's often resistant, and it has certain typical characteristics. First of all, resistant hypertension is very, very common in obstructive sleep apnea. The definition of resistant hypertension or refractory hypertension is when you use 3 drugs in full doses taken regularly with good adherence to treatment, and still the blood pressure is not controlled. At least one of those drugs should be a diuretic. So that would define resistant hypertension. Then you have the nocturnal hypertension. Typically, BP comes down at night, but you can see when an ambulatory BP recording is done, that's the blue thing just below the first bar, the middle on the left. You can see that at night, there's a huge rise in the blood pressure very often, surges in blood pressure. And then this can continue in the early morning. There's another huge surge of blood pressure, and then it kind of settles down but remains elevated through the day. Many of these patients have a difference between the 2 arm readings in BP. So in all your patients with obstructive sleep apnea, please check the BP in both upper limbs. This is because they tend to have a lot of subclavian or brachial artery atherosclerosis, which drops the blood pressure. They also suffer from endothelial dysfunction, as mentioned earlier, along with increased arterial stiffness. And this leads to aortic dilatation, leading to either an aortic aneurysm or a rupture in the endothelium, leading to aortic dissection. Atrial fibrillation is common, and I'll come back to, but a classic feature is left ventricular hypertrophy. And more we are realizing that a lot of these patients present with diastolic dysfunction, or as we call it, heart failure with preserved ejection fraction. And you'll see that when a person has these, the CPAP treated patients should ideally be receiving ARBs either by themselves or in combination with other drug classes, while those who don't take CPAP will probably do better with beta blockers, diuretics, and calcium channel blockers. And over time, we've learned that probably the SGLT2 inhibitors and GLP agonists, receptor agonists, seem to have a good role when there is heart failure with preserved ejection fraction. And I find that I make a diagnosis of heart failure with preserved ejection fraction in a lot of my patients with OSA. So the likelihood of having hypertension is not just common in OSA, its likelihood rises with the severity of the OSA, as the Sleep Heart study showed, one of the major studies available to us for a very long time. So how do you know your patients who have hypertension are going to respond well to obstructive sleep apnea treatment, CPAP in this case? Those who are have good adherence to CPAP treatment, those who have excessive daytime sleepiness actually do better than those who don't. Those who have resistant hypertension actually do well. Those with refractory hypertension do well. And the one I mentioned earlier, the non-dipping BP profile, especially when they have tachycardia, all these are manifestations that are likely to settle when you put them on CPAP treatment. We know that if you look at overall, on the left, you have the cumulative incidence of fatal cardiovascular events. On the right, you have non-fatal cardiovascular events. The controls are at the bottom, the solid line, and those who have severe obstructive sleep apnea are with the dotted lines right on top, the little squares. Those are the ones who are most likely to have more fatal and non-fatal cardiovascular events. Those with milder disease also, that is the solid line, the thinner line in between. But when you put patients with obstructive sleep apnea, hypopnea on treatment with CPAP, they seem to do better. They almost catch up with the normal controls. We know that cardiovascular diseases start off as cardiometabolic diseases. And we look at all the risk factors on the left. Obstructive sleep apnea is closely associated with all of these, as highlighted in the red rectangle on the right. A very high association, whether you're talking about diabetes, obesity, hypertension, dyslipidemia, and the consequences of that as disease. Almost all other parameters, including biochemical and demographic parameters, again, are worse in patients with OSA and worse in those with severe OSA. Pulmonary hypertension was present in about 25% of patients with OSA. OSA was present in 25% of patients with pulmonary hypertension, but very often this is group 2 pulmonary hypertension and not group 3 pulmonary hypertension. And again, this is as a consequence of the diastolic dysfunction, and many patients tend to have a mixture of both group 2 and group 3, a combined pre- and post-capillary pulmonary hypertension. Cardiac arrhythmias are common. This is a nice recording of a person who had a prolonged ventricular asystole. And then this is often followed by tachycardia when the apnea is over. And then the patient gets tachycardic. So a cardiologist may often recognize this as tachybrady syndrome. And I've had quite a few patients who actually had obstructive sleep apnea, but had received a pacemaker for so-called tachybrady syndrome, because that's what the Holter monitor picked up. Atrial fibrillation. About 50% of patients who have atrial fibrillation, it's been directly associated with sleep apnea. And we know that atrial fibrillation increases the risk of stroke 5-fold. And this persists even after the atrial fibrillation is treated. And if you don't treat the sleep apnea, the risk is multiplied several-fold. So in fact, one of the persons who commonly refers patients to us, not one of the patients, our arrhythmia clinic team are totally clued in on this and refer a lot of patients with atrial fibrillation to us for sleep apnea evaluation. The other main referrals come from patients who've had stroke, especially the young strokes. So this is the sequence of events that happens. I'm not going to take you through the top, a lot of complex electrophysiology, but what is very clear is that you look at the bottom right, there is an increase in atrial fibrillation risk in those who receive just standard care, or whereas patients who receive treatment with CPAP actually do better, and they have a better survival free of atrial fibrillation. But both treated and untreated patients actually don't do quite as well as those who don't have OSA. So again, I think the problem is because we come on this after significant cardiac damage has happened. Atrial fibrillation is largely due to the left atrial enlargement that occurs, to the consequent changes in the size of the LA frequently, the consequent fibrosis, and that leads to the circus movement indicated in this, in the top right, left-hand corner. The last part which says fibrosis, that leads to circus movement within the atrium, and a consequence of this is atrial fibrillation. We also know that sudden cardiac death is more common at night in patients who have OSA, and this is what this graph shows. You look at the patients who had total sudden cardiac deaths from cardiac causes, and between midnight and 6 a.m., those with the white bars are those who have OSA, and you find that they strongly outnumber those who have sudden cardiac death due to other non-OSA conditions. And while those catch up during the rest of the day between 6 a.m. and 12 midnight, if a person has a sudden cardiac death, these tend not to be OSA patients. They can be OSA patients, but they tend not to be OSA patients. So essentially, patients have sudden cardiac death at night. Consider the possibility that maybe they had sudden obstructive sleep apnea. We also know that the odds of stroke increase with the severity of OSA. On the extreme left, you find those who have mild OSA. And as you move higher and higher with the apnea-hypopnea index, which incidentally is not a great measure of the consequences of obstructive sleep apnea, you'll find that the increasing OSA severity is paralleled by increased odds of having a stroke. And when you look at all cardiac deaths, you can see that prevalent cardiac disease in patients with OSA is 2.5 times those who don't have OSA. And when you go from snoring to mild to moderate to severe untreated OSA, you will find a significant rise in the odds ratio of having a cardiac event, a cardiovascular death, I should say. And when you treat them with obstructive sleep apnea, this study showed that you actually brought it down almost to the same level of somebody who did not have obstructive sleep apnea. Moving on from cardiovascular disease to metabolic consequences, again, you go through practically the same set of problems. But here you see that sleep fragmentation is associated with increased sympathetic neural activity, a lot of oxidative stress, driving systemic inflammation. And because of this stress, there's activation of the HPA axis, which worsens cortisol, which increases cortisol production. There's an alteration of the circulating adipokines. There is also leptin resistance that develops, which is not indicated in this particular diagram. There is also intermittent hypoxia contributing to the same set of factors. All these lead to beta cell dysfunction on the one hand because of inflammation, insulin resistance on the other. There is hypertension, as we already said, and that combined with either impaired glucose tolerance or diabetes leads to the micro and macrovascular complications of diabetes. And this was a very nice report in Chest, a review, which showed that as you move from sleep restriction or sleep fragmentation, especially when associated with hypoxia, insulin sensitivity dropped anywhere from, say, 16% to 24 to 25%. There was a drop in insulin sensitivity. In short, insulin resistance increased. And so lack of good quality sleep is known to produce insulin resistance. And we've just completed a study that shows the same thing. We haven't reported it yet, so I haven't put it here. The risk of incident diabetes, not just impaired glucose tolerance, increases. And you can see that the risk is higher by about 35% in patients who have obstructive sleep apnea. And then when you put patients with OSA on CPAP and you follow them up over time, you will find that those who are treated, that's the orange solid line, the risk of developing diabetes, the incidence of diabetes comes down in patients who are treated as compared to those who are untreated and have severe OSA. That's the top dashed gray line. The third group that we are finding more and more, and we have come to realize that OSA underlies them or is associated with them, are those with metabolic disease associated fatty liver disease. It's on the left, runs through the gamut of dyslipidemia, insulin resistance, which I've also already spoken about, which leads to fat deposition within the liver. We know more and more that hypoxia leads to dysbiosis. The gut microbiome changes, the gut epithelium becomes more leaky, bacteria move into the circulation and cause a whole lot of systemic consequences, including systemic inflammation. And there is death of cells due to all these factors, inflammation, apoptosis, and hypoxia put together. And that drives a move from a healthy liver through fatty liver disease to steatohepatitis to sometimes the development of hepatocellular carcinoma. And on the right, you have various things that I've just spoken about, dysbiosis, damaging the gut wall integrity, and so on, associated with hypoxia and the sympathetic activity. And we know that as one moves from simple snoring to mild, moderate, and severe OSA, the incidence of hepatic steatosis rises from 42% to 63 to 79% as the severity worsens. Even simple snoring, because it's often associated with obesity, is associated with fatty liver disease. And there was a big difference between the simple snorers and those with severe OSA. And the parameters associated with polysomnography as you move from non-NAFL to the mild fatty liver disease to the moderate to the severe fatty liver disease, the apnea-hypopnea index keeps increasing. So the various measures, and I think it's more important to look at the oxygen desaturation index, the lowest desaturation, and the nocturnal amount of time you spend below 90, those are all strongly associated with the severity of the fatty liver disease. This was a study we did a couple of years ago, again showing you the same thing, that as one moves from the OSA low risk as per the stop bank score to a high risk, you have a much higher incidence of fatty liver disease. The orange bars in the bar graph below, as the severity increases, the severity of NAFLD also increases. We showed that by looking at ultrasonography, but also by the FIB4 score, again showing you that as the OSA got worse, the severity of NAFLD got worse and worse. The other great worry is of dementia. And you can see here that when you compare those, the dotted lines, with those who have OSA, the solid lines, you find a significant increase in the dementia confidence intervals, both on the left and the right. As we grow older, dementia, of course, increases, but it increases more steeply and at an earlier stage. So you can see that even at the age of 60, there's a significant increased risk of having dementia when a person has OSA as compared to those who don't have OSA. We did this study a few years ago, presented at the ERS, that cognitive impairment occurred much more commonly, almost twice as common or more in those with obstructive sleep apnea as compared to those who don't have obstructive sleep apnea. And this occurred across various cognitive domains, where we're talking about memory or attention or executive function. All of them made more errors in the battery of tests. And apart from neurocognitive decline, we also saw a much greater increase in anxiety and depression. And in fact, until a few years ago, one of the people who used to refer patients to me commonly for screening for OSA was a psychiatrist, because he was aware that a lot of his patients improved very well when they went on CPAP treatment. And unfortunately, all these add to an increase in mortality, and this is in a dose-dependent fashion. Again, you see that as the apnea-hypopnea index increases, greater than 30, as compared to somebody who has no sleep apnea, and those who have in between mild and moderate sleep apnea, the probability of survival drops steeply as you have more severe sleep apnea. The big question now, because you've got to show the opposite, you've got to show that if comorbidities occur due to sleep apnea, it will become more solid if you can show that treatment for sleep apnea actually reverses these comorbidities. And that will, strengthen the link that says OSA is responsible for these comorbidities. So does CPAP work? We know that CPAP leads to weight loss. Unfortunately, this is not a very consistent effect. We know that this I've shown you earlier, that there is changes in the ventricular structure. I showed you the study earlier. I didn't show you this, and shown you that after you start CPAP, there's a significant improvement in many of the parameters, including objective parameters like BP, left ventricular function and structure, and this is both systolic and diastolic function. We know that diabetes, pre and post therapy, shows you a very significant improvement. On the left, you can see the mean glucose before and after treatment. Before treatment in green, after treatment in blue. And for those who use CPAP for more than 4 hours, you get better improvements than those who use CPAP for less than 4 hours, telling you that a minimum of 4 hours of treatment with CPAP is necessary to get benefits from it. Okay, and on the right, you have insulin sensitivity, which improved within 2 days of starting CPAP treatment and improved further after 3 months. So you got very significant improvements in control of diabetes and improving insulin sensitivity when a patient started CPAP. Unfortunately, CPAP needs to be started early. This was one of the worrying studies that came out about 8 years ago, McAvoy's study, which showed that when you looked at cardiovascular risk using a primary endpoint of death from cardiovascular causes or major adverse cardiac events, including transient ischemic attacks or hospitalization for heart failure, after an initial apparent separation the final outcome was there was no difference whether a person received CPAP or didn't receive CPAP. And the problem is that this study took patients who were fairly advanced, had established cardiovascular disease. And I think the message for us is that if you have established cardiovascular disease, it's too late to perhaps start your treatment. By all means, start treatment. I think it does make a difference, but in the long run, you may not get the benefits that you will get if you start treatment very early. Again, very good studies. Just focus on the MAFL risk in the right-hand column. Treatment with OSA reduced many of the parameters associated with metabolic disease-associated fatty liver disease. There were a couple of studies that were outliers. CPAP alone did not improve hepatic steatosis and fibrosis, the last but one. But otherwise, most of them showed improved non-invasive markers of fatty liver disease. So again, as I said, established CVD, no improvement. So I'll leave you with a few key messages. Obstructive sleep apnea is associated with several comorbidities and multimorbidities. It's associated with a poorer quality of life, associated with an increased mortality. The severity of the OSA is often correlated with the severity of the comorbidity. Sorry, that should be changed. The severity of the OSA is correlated with the severity of the comorbidities. The underlying mechanisms for the systemic involvement, including inflammation, are complex. They involve responses to hypoxia, hemodynamic disturbances, hormonal changes, resistance to insulin, and leptin included. In everybody with OSA, all your patients, please look for the comorbidities so you can catch them and intervene early. Conversely, when you have patients with these comorbidities, hypertension, cardiovascular disease, poorly controlled hypertension or diabetes, strokes, psychiatric abnormalities, early dementia, please look for OSA in these patients. And unfortunately, in causes of reversible dementia, OSA is not included, but I think we can make a case for it. And finally, treatments for OSA may reduce the risk associated with comorbidities if instituted early. Thank you so much, and thank you to Dr. Amita and the ICS for inviting me to give this talk.
So, thanks a lot. Thanks a lot, Dr. Murli Mohan. It's an amazing talk, and I think this was just a masterclass on obstructive sleep apnea, its comorbidities, why it is important to diagnose and treat obstructive sleep apnea, and what are its associations and limitations. And I think limitations, as which were highlighted towards the end, in my view, are possibly because of limitations of the studies, because what we see practically and what Dr. Murli Mohan mentioned was there's a tremendous benefit in patients who have, who are treated with CPAP all across, whenever, at whatever stage you find them. And of course, the message is also very clear that it should be instituted early and it should be started, and you should look for comorbidities. Now, to take this entire discussion further, and to look at sleep apnea and discuss sleep apnea from a much more broader perspective with the entire national experience. We've got an amazing panel today with a lot of experience and focus and passion about sleep apnea, who are going to help us, along with Dr. Murli Mohan, to discuss certain questions. So, Dr. Murli Mohan, you've already heard him, and he's his introduction is clear. And of course, his introduction became stronger after that amazing talk. So in the panel discussion, we've got with us four very experienced pulmonologists who are going to share and discuss their experience and literature and teach us about sleep apnea further. And first is Professor Dr. Girija Nair. She's the professor and head of pulmonary medicine department at DY Patil Hospital in Navi Mumbai. She's an ACCP fellow. She's got awards and achievements for the best department in 2024. She had the Bansal Award in 2015. And amazing, she's mentored more than 50 postgraduate students. She's got more than 50 research projects going on and 100 research papers published in national and international journals. And she is also a peer reviewer for the Lung India and the Journal of COPD. So, Madam, great that you join us and welcome. Next, I would like to introduce Dr. Aakanksha Chawla Jain, who's a consultant in respiratory critical care and sleep medicine at the Indraprasth Apollo Hospitals in New Delhi. She's got multiple awards and achievements to her credit, including the award from the Indian Journal of Critical Care Medicine in 2020. She's got the first prize at NAPCON 2014. She's got also an award from the American Journal of Infections and Control in 2023. She's also got an award from the British Journal of Anesthesia in 2023. And she's also publishing quite well. She's got a book. She's got contributions also to books and chapters in critical care medicine, critical care updates, almost on a regular basis. Perioperative critical care, Tata Memorial Hospital, and then the ISCCM manual on non-invasive ventilation and ICU protocols. So amazing profile, Dr. Aakanksha, welcome. I would also like to introduce Dr. Kripesh Sarmah, who is a senior consultant and the head of Department of Pulmonary Medicine at the Apollo Hospitals in Guwahati. Okay, he's past professional experience includes working as an assistant professor in pulmonary medicine at GMCH. He's been a resident at the VP Chest Institute in Delhi, and his interests are pulmonary interventions such as bronchoscopy, thoracoscopy, EBUS, TBNA, and a wide array of pulmonary medicine, clinical aspects of pulmonary medicine, I would say, asthma, COPD, ILD, sleep apnea, and TB. And he's got also, multiple achievements with him. He's been faculty at the ERS India Summit at NAPCON. He's a governor of Northeast CCI. He's member of the ICS, NCCP, ERS, and he's a fellow of the National College of Chest Physicians and has been awarded by the Times of India Group and News 18. So amazing, Dr. Kripesh. We look forward also to learning from you. And lastly, I would like to introduce Dr. Aruna Shanmuganathan, who is a professor at the Department of Respiratory Medicine at the Kalpaga Vinayaga Institute of Medical Sciences, Tamil Nadu. And she's also a very senior consultant at the Apollo Clinic in Chennai and at the SRM Global Hospitals in Chennai. She's got nearly 25 years of PG and UG teaching experience, published more than 30 papers. She's also authored a chapter in book on pulmonary disorders in women. She's a peer reviewer for JAPI. She's completed the ATS and the ICS, McCord specialized training in clinical and operational research. And her special interest includes sleep medicine, and that's what we're going to learn, airway disease, ILDs, and pulmonary rehab. So with that introduction, I would now like to move on to the panel discussion. I need to stop.
Can I interrupt you for a second, Prashant, and introduce you?
Okay. Yes, so, thanks.
Can I have the slide for the formal introduction? But let me start. Prashant is, of course, a wonderful speaker, one of the most respected interventional pulmonologists from Mumbai. We've seen him publish papers in interventional pulmonology repeatedly. He was trained, of course, in Bombay and went abroad for his interventional pulmonology training to Switzerland, where he's worked with some of the finest interventional pulmonologists in the world. And he's carried that experience and developed it to a greater level. So, Prashant, it's wonderful to have you, moderate the session, and we're looking forward to it. Okay. And of course,
Prashant, so even
I've known for a long time also. So
yes. Dear friend, Murli, dear friend. Yes. So thanks a lot for that introduction. And now we move on to the panel discussion. And I think the panel discussion will also touch upon certain points which Dr. Murli mentioned, and albeit in a little bit more detail. So the first question which I would like to ask, or the point to discuss is with Dr. Girija. What is the definition of OSA? What is the prevalence in India and the world?
Ma'am, you're
muted. You need to unmute, Dr. Girija. Yeah. Yeah, you just need to unmute, Dr. Girija. Is there on the screen?
Yeah. Hello, you can hear me now?
Yes, we can hear you. Yes.
Yeah. Thank you. Yeah. Now, after that lovely introduction and the great talk by Dr. Murli Mohan, let me just start my. You have asked me the definition of OSA. It is basically a sleep disorder which is characterized by repeated episodes of complete, maybe, that is called as apnea, or partial, which is hypopnea, collapse, or airway airflow obstruction, which we can say, and this leads to oxygen desaturation or sleep arousal. So there are episodes, recurrent episodes of apnea and hypopnea now, and which is leading to oxygen desaturation and sleep arousals or sleep arousals. Now, apnea means complete cessation or a more than 90% reduction in the airflow for more than 10 seconds is what is apnea is defined as by the ASM. And hypopnea is around 30% of the reduction of airflow, along with 3% or 4% reduction in drop in oxygen levels. Now, AHI definition, what as per the apnea, hypopnea, or the RDI index is more than 5, is considered as a OSA. 5 to 10 is considered as mild OSA. 10 to 15 is moderate, and severe is more than 15 AHIs. Now, let me go to the other question, which is the incidence or the prevalence in India. The prevalence, there was a good study which was done, a meta-analysis done and presented, I think last year, 2023, by the AIMS people. Dr. Anant Mohan and his group had done it from AIMS. So they said the prevalence in India is around, of OSA is 11%. What they did was a meta-analysis of more than 11,000 subjects were analyzed, and 8 studies, all over Indian studies, were analyzed. It was a systematic review with a meta-analysis. And they said that they found the overall prevalence was 11%, with the gender difference of males being 13% and female is 5% prevalence of OSA. And urban versus rural also, they found some difference, 4.6% in urban and 3.7% as rural. And out of all these people, which was mostly in the 35 to 47 years of age, that is a working population, they found a 5% people had moderate to severe OSA. So in our country, about 104 million Indians of working age are suffering from OSA actually. And out of them, 47 million have moderate to severe OSA. This is the prevalence which they have identified in this systematic review.
Yeah, right. So I think the message that comes across is that the prevalence is very high, okay, of sleep apnea, and as Dr. Murli also very well, put across and very crisply, that we need to look for sleep apnea, we need to diagnose them early and institute early, because that's what is emerging, that if you treat them early, then that's probably going to help in the long term. So Dr. Aruna, if I can ask you, what are the nocturnal symptoms which are typically described by the patient and by the spouse? So, just to highlight that whenever we are interviewing patients for sleep apnea, or if the patient has a partner or a spouse, that partner is also involved in the contribution to the clinical assessment.
Yes, thank you for your question, sir. And at the outset, I would first like to congratulate the ICS and the entire team for their wonderful initiative of having the sleep certification course, and a special thanks to Dr. Amita for having me here to participate in today's session. So, addressing the nocturnal symptoms of OSA, as very well put by you, sir, what are the symptoms as told by the spouse to the doctor and what the patient complains of. So, more often than not, we see the spouse or the bed partner or the person who's sleeping with the patient often bringing the patient to our clinic with a complaint of loud habitual snoring, because obviously it's the sleep quality of the spouse or the partner is getting impaired. So that is one of the primary reasons why the patient is brought in, though many patients don't realize also that they snore. Of course, we have some patients also who says, yes, I am aware, doctor, that I snore. So one of the salient complaints is a loud snoring. The next important symptom is often the partners notice breathing pauses, or what we technically call as witnessed apneic episodes. So at certain periods of the night, they observe that the partner has just stopped breathing. So this is also an important observation complained by the spouse to the doctor. And they also see that the patient is quite restless with some frequent arousals and some body movements. So usually the body movements are not very common in OSA, maybe 20 to 25%, not as common in the other periodic limb movements which are picked up in incidentally level 1 studies where the video is there and you can pick up limb movements. So, and of course, this is a gist of the symptoms which are complained by the spouse. The patient, when they come in, of course, the primary symptom is there related to the sleep fragmentation. So it's the excessive daytime sleepiness, and this is in the daytime. But the nighttime symptoms, what the patient complains is a choking or a gasping sensation. So the patient often says that it's like an air hunger. They say that I can't breathe suddenly. So it's almost like a panic attack. Sometimes you get confused. And they also complain of frequent awakenings, arousals, and nocturia. Probably in sleep apnea, one of the hypothesized mechanism is atrial stretching, which leads to increased release of the ANP, and that leads to the secretion of sodium secretion in the urine, probably contributing to the nocturia. So these are the common symptoms that patients at night complain of. Of course, there is a huge list of differential diagnoses for these gasping or choking attacks. And frequently, they also have abnormal breathing patterns also. Like this is frequently observed in children. Parents complain that children often have paradoxical breathing, or they sleep with a hyperextended neck and so forth, or mouth breathing. And patients also do have nocturnal symptoms of a dry mouth or a sore throat when they awaken at night. So this is in summary the important symptoms as told to the doctor by the spouse and by the patients.
So I think that's very well covered. I think from the symptoms perspective, and what I would like to ask Dr. Kripesh is: are there any differences between men and women?
Yes, sir.
I'd like to ask Dr. Kripesh. Dr. Kripesh, please. Yeah, thank you.
Thank you, sir. First of all, I like to congratulate Indian Chest Society, particularly Dr. Amita ma'am, for this very wonderful course on sleep medicine. So there are a little bit difference between men and women regarding presentation in OSA. So men usually present a classical symptom of OSA, but in women will have a little different from men. They will have a more of a symptoms like a fatigue or insomnia, or they will have more of a restlessness or some depression or more headaches and muscle pain. These are a little bit atypical presentation which we can see more in a woman compared to men, where we can see more of a classical symptom of OSA like snoring or witness apnea or daytime sleepiness. So these are the major difference where in clinical presentation of OSA among men and women.
So I think that's very well covered. And I must tell you a funny story also, where a female patient who's a housewife, and and she presented, and one of the symptoms she said was that while she was cooking, sometimes she was overcooking things and not realizing that that the appropriate time to be spent for a particular dish. So that was something that was happening repeatedly, and it was amazing that people come out with different symptoms as we see more and more patients with sleep apnea. So, Dr. Aakanksha, I would like to ask you: is there any difference between, as far as the presentation of sleep apnea is concerned, between an adult and a pediatric patient? Anything?
Thank you for introducing me, sir, and thank you for the question. I would also like to thank the Indian Chest Society and Dr. Amita Nene, ma'am, for having me today on this discussion. So when we talk about the adult and the pediatric population, they are at two ends of a spectrum. If you look at it, there is a wide difference, sir. The major problem in children usually is adenotonsillar hypertrophy, more than obesity. Whereas in adults, we would see obesity, reduced neuromuscular tone, as well as upper airway anatomy as the issues. Now, when you look at the presentation, a child would present with hyperactivity. He would be an hyperactive child, or would have attention deficit problems, or maybe even poor school performance. Whereas an adult would have excessive daytime sleepiness, fatigue, cognitive dysfunction. Now, snoring, which is often underestimated in children, also does happen in children, but they would have restless sleep. They would have nocturnal enuresis. Whereas in adults, we've been talking about it, loud snoring, witnessed apneas, as well as insomnia are the issues. Then in adults and in children, when you look at the growth, there is obesity in adults, whereas in children there is a significant growth retardation, which is seen associated with OSA as well. And we talk about the diagnosis, polysomnography obviously remains the gold standard. But when we look at the AHI, we consider an AHI of 5 or more as the diagnostic criteria for adults. But in children, even 1 or more than 1 is considered significant. So that is something very important. And again, when we talk about the treatment per se, we think of CPAP as the mainstay of treatment. But in children, it is the tonsilotectomy, which should be done as the first, if that is the major cause, which usually is the commonest problem. And CPAP is very reserved for the residual cases. So OSA in children is often an underdiagnosed problem because they're usually present with hyperactivity, ADHD kind of behavior. So it is usually a delayed diagnosis in the pediatric population.
Yeah, right. So that's amazing. I think that's fantastic. Just description and about the differences between adult and children sleep apnea, how they present differently, and I think the role of surgery is also more in the children population, as has been rightly highlighted. So I think that's what we need to understand. And one of the things is the scholastic backwardness. So now that I just want to share a story where we identify certain kids with scholastic backwardness, snoring, etc. And the kids sleeping in the class, not focusing, and we made some the diagnosis and the treatment, and the response has been so dramatic. The minute you do the surgery, it's sometimes difficult to believe for the children, for the parents, as well as for the children. So it's now become, and as this awareness increases, you will, and you encourage the school teachers. I think you can add. I think the school teachers are the target who need to be educated, and then we can pick them up more, and we can, identify them more and treat them more. And I would say it's very gratifying to identify these kids and treat them. So moving forward, Murli, can you just briefly tell us about the pathophysiology of OSA? Just a brief summary. I know you referred to that a little bit, but then if you can cover that for us, please.
Sure. So, Dr. Girija ma'am has already referred to the obstructions that happen, and the consequences of these obstructions are primarily hypoxia and sometimes hypercarbia. And you get these shifts. These are intermittent hypoxias. And that works through a variety of mechanisms to increase systemic inflammation. The second thing that's happening, as I spoke during my talk, is the obstruction leads to huge shifts in the intrathoracic pressure, which causes, as a consequence, huge shifts in the blood flow into and out of the chest. The third is you have sympathetic overactivity as a result of this, and that therefore will drive the blood pressure and has consequences on the heart itself. So it causes tachycardia on the one hand, and it pushes up the BP, and you get swings in the blood pressure also, which therefore affect the endothelium as well as the media of the arteries, making them stiffer and causing endothelial dysfunction. And finally, you have the hormonal changes that happen. So you have leptin resistance that builds up. There are changes in the orexin neurons in the brain and the orexin that they produce. You have changes in adiponectin, but these are not very clear. We know leptin resistance exists, and the function of leptin is to keep a person thin, to burn calories, and to burn off carbon dioxide. So when you have a leptin resistance, the person puts on weight. The person does not burn off calories, so they put on weight for that reason also. And the third is they tend to accumulate carbon dioxide. They don't blow it off. We don't have these hormonal changes that clear. What we do know is insulin sensitivity comes down, and as a consequence, you have not just diabetes, but you also have the other metabolic parameters, including fatty liver disease, atherosclerosis, and so on. So that's the links between the different pathophysiological processes that are driving obstructive sleep apnea.
So I think that's so well explained, and I think it's so important.
Sorry, can I just add one thing? One of the things that happens, especially as people go into failure, start retaining fluid, is that when they go to sleep, the upper airway starts to gain more fluid, and that contributes to the worsening failure in them. So starting CPAP early may actually reverse some of these changes, and that's one of the reasons why patients with heart failure do pretty well when you start them on just CPAP. You don't even need to use anything else.
Yeah, so if you want to just take the one of the a question which has come in the chat boxes, how is heart failure with preserved ejection fraction diagnosed? My cardiologist seldom gives that diagnosis, and I think I think this has been already partly explained by Dr. Murli. And NT-proBNP is a very good method where you can you can diagnose cardiac failure, and these individuals on 2D echo may still show a preserved ejection fraction, maybe 50, 55, or 60%. So, Dr. Girija, now can you very briefly tell us about the Epworth Sleepiness Scale?
Yeah, Epworth Sleepiness Scale is actually a self-administered test, which the patient will you give them some questions and they answer it, and this is to help us to diagnose the daytime sleepiness. So it will identify whether what is the amount or there is daytime sleepiness. So there are a few questions. There are 8 questions which we give, and they are recorded from 0 to 3 points. They are given, and 0 means he does not have any chance of dozing or falling asleep, and 3 is he has very high chance of falling or dozing or falling asleep in the different settings. So if we go to, and the maximum he will get, because there are 8 questions and maximum is 8 points, so he will get 24 points. So the basic, as I can tell you, the questions will include the chance of falling asleep while sitting or reading. Second is watching TV. Third is sitting inactive in a public place or as a passenger in the car. Then lying down for rest after lunch, sitting and talking. And these are other things when he stopped in a car. So these are 8 questions which we ask them, and whether they fall, what are the chances of them falling, dozing or falling asleep, and it is a self-administered questionnaire. Now, if he gets 0 to 5 points, there is lower than normal chance of him having a daytime sleepiness, while 6 to 10, he has a higher than normal. But more than 10, definitely he has a mild excessive daytime sleepiness. 13 to 15, moderate excessive daytime sleepiness, and 16 to 24, he has severe daytime sleepiness. So this is to judge whether we have to, go for the PSG polysomnography, or the patient has to be referred to a sleep specialist. And what is excessive daytime sleepiness? It is a condition characterized by persistent sleepiness and a lack of energy even after sufficient sleep. So even daytime he will have sleep, and he may have enough sleep or he may not have enough sleep, but he will have daytime sleepiness extra. So it may affect even 20% of the population, seen in many patients having, of course, OSA, but it can encompass other diseases like narcolepsy, even circadian rhythm sleep disorders like jet lag, or shift work also. But idiopathic also is there, drug abuse, people having tumors, head trauma, hypothyroidism, even long COVID is known to have this excessive daytime sleepiness. So for that, we need to try to do the ESS, or the Epworth Sleepiness Scale, and try to identify how much he has daytime sleepiness, if that is in short.
No, yeah. So I think that is very well explained. I think the Epworth Sleepiness Scale is a part of an important part of the sleep clinic and the sleep practice. And one has to understand that just having a Epworth Sleepiness Scale showing that there is excessive sleepiness is equal to sleep apnea. That's not correct. I think the ESS just tells you the degree of sleepiness that individual has. And of course, if there's a pre-test probability of sleep apnea, then yes, you're going to go and do the required things to diagnose sleep apnea. But if that individual does not have sleep apnea, then it should not be left alone. You need to work it up further. And therefore, now to take it this point further, I would like to ask Dr. Aruna, what is the difference between benign between sleep apnea and benign snoring? So snoring is present in sleep apnea as well as in you may have snoring but not sleep apnea. So what's the difference, and how do we go ahead in this?
Yes, sir. So, though snoring is one of the cardinal symptoms of OSA, all snorers may not have OSA. So that is what it is. So we have to look at the spectrum of sleep disordered breathing as a level of increasing airway resistance, upper airway resistance. So at the beginning, we have at the one end, we have the primary or the benign or the simple snoring as to start with. And then we move on to a phenomenon that is a concept of UARS, upper airway resistance syndrome. And then we move on to obesity, that is the obstructive hyperventilation. And finally, we have the OSA. So to come to your question regarding how to differentiate a simple snorer from a snorer having an underlying OSA. So the simple or the benign snoring, as you have put it across, is not associated with the classical symptoms of OSA. That is the symptoms which arise due to sleep fragmentation, the nocturnal or the daytime symptoms which have already been discussed. So these are not classically seen. And usually in these benign, the primary snoring, the sleep architecture is maintained. There is no evidence of any airflow limitation. The apnea, hypopnea indices are quite normal. There is no significant desaturation. However, and the type of snoring also, if you look at it, it is the snoring in OSA is a crescendo type of snoring. The intensity goes on increasing till you get a point where the breathing stops. That is the witnessed apnea or the breathing pause. And then at that time, the patient usually comes up with a classical symptom of having a choking or a gasping sensation. And then the episode, the arousal happens, and then he goes back to snoring. But in a simple snoring, these are not associated with any breathing pauses at all. So this is the how we mainly differentiate the two. And the other concept of the upper airway resistance syndrome. So in upper airway resistance syndrome, they do have an airflow limitation, which is associated with the RERAs, that is the respiratory event related arousals. And they do have symptoms related to sleep fragmentation. So this is the difference between the benign snorers and the UARS group. And the benign snorers, usually we have to evaluate them. Not all snorers need a PSG, but however, if we do find the risk factors that they are obese and the male and aging and things like that, we do have to follow up these patients. Simple advice is like ruling out any nasal congestion, polyps in the upper airway, and addressing those issues or advising a sleep posture change also helps a lot of these patients.
So I think that's very well explained about the difference between just benign snoring and the snoring that is associated with sleep apnea. So now we are taking this further in the flow. I'd like to ask Dr. Kripesh, what are the anatomical factors that are responsible for obstructive sleep apnea?
Yes, okay. There are several anatomical factors are basically important for sleep apnea. And basically, this can be divided into factors related to your pharynx, our tongue, and the soft tissue, soft palate. So basically, in pharyngeal factors, like there is a enlarged tonsils or adenoids, particularly which we can see in the pediatric case group more commonly. Then a narrow pharyngeal airway, like a small cross-sectional area, has been reduced or increased airway pharyngeal resistance can be seen. Then there may be because of the excessive soft tissue deposition, or there is a decreased muscle tone of the pharyngeal muscle. So these are the pharyngeal factors. Then tongue-related factors are, there may be a macroglossia or enlarged tongue, or retroglossia where tongues are a little bit posteriorly placed. Then soft palate factors, like there may be an enlarged or elongated soft palate, or abnormal position of the soft palate, which make the upper airway more narrowing during the sleep time. Apart from these three main anatomical changes, there are also craniofacial abnormalities, which are like your retrogantria, or this is where small or lower jaws, or there is an underdeveloped mid-facial abnormalities or mandibular hypoplasias are also associated with OSS. Then there are also abnormalities like your hyoid bone abnormalities, particularly in upper way, are also responsible for in the development of OSA when this sort of anatomical abnormalities present.
So amazing. I think so. That's see. I think sleep apnea, the upper airway obstruction in sleep apnea has multiple contributors. So the anatomical factors which have been responsible have been highlighted. The next I would like to ask, there are multiple risk factors which we'll discuss. And the next point I would like to request is Dr. Aakanksha, can you highlight us on the neuromuscular factors that are responsible for OSA?
Right, sir. So, sir, in OSA, basically there is upper airway muscle dysfunction, especially during the REM phase. There is reduced tone of the pharyngeal dilator muscles, which leads to the airway collapse. Apart from that, we have the blunted negative pressure reflex, which normally activates the dilator muscles during inspiration. And I think anatomical predisposition like the narrow airway, large tonsils, tongue, high Malampati scoring, fat around the neck and parapharyngeal space also increases the collapsibility. So these majorly contribute to the neuromuscular factors for OSA.
OSA. So, so now that we've learned about the anatomical factors, the neuromuscular factors. Now I would like to ask Dr. Murli, can you just explain to us the non-structural and the endocrine risk factors which are associated with obstructive sleep apnea?
So, one of the most commonly seen non-structural risk factors, which actually contributes to a structural change, is obesity itself. Of course, while we say that, we must remember that about 10% of patients with sleep apnea are non-obese. I am the classic example. I'm non-obese, I have sleep apnea. It's also important to look at the distribution of fat. So when you see that patients tend to have a lot of central fat, they tend to be the ones who have a higher chance of having sleep apnea. We know that the male gender has more likely sleep apnea. In fact, most studies show that sleep apnea is twice as common in men than in women, but this is in the younger age groups. And as they grow older, both genders tend to have a higher risk of having sleep apnea. So age is an important risk factor. And at some point, the women seem to catch up with the men post-menopausally, like we've seen with coronary artery disease. Sleep apnea also becomes more and more common as women tend to grow older and almost catch up with the men. One of the main risk factors, of course, is the use of alcohol and other sedatives, and especially when people try to sleep because they feel they've not slept enough. I think Dr. Kripesh already told us that some of them tend to have insomnia, especially the women. They tend to use sedatives, and this aggravates the sleep apnea. Similarly, men tend to use a lot of alcohol, especially with the nightcap. That can precipitate sleep apnea. We know that smoking is associated with sleep apnea, both in terms of probably increasing the risk by producing local changes, but also by increasing the comorbidities that get aggravated when a person has OSA and smokes. One of the typical things that we see is those who sleep on the back. So in fact, when a patient tells me I can't sleep on my back, I can only sleep on my side, that itself is a good indicator that the person has most probably got obstructive sleep apnea for the various anatomical reasons that people have mentioned. So these are all the non-structural risk factors that seem to contribute to sleep apnea. The hormonal things that you mentioned, of course, patients, these are both endogenous and exogenous. So people who take steroids, for example, Dr. Aakanksha already referred to the neuromuscular factors. So when you use steroids, for example, muscle weakness occurs, and that tends to cause an increased risk of having sleep apnea. And then you have patients who receive hormones that can actually increase their weight, insulin being the classic example. So they have insulin resistance, they receive insulin, and they tend to put on weight, and that drives also part of their sleep apnea and also leads to fat distribution. I've already mentioned earlier the less well-known hormones, including leptin and adiponectin and so on. And finally, we know these days with the advent of the GLP-1 agonists that probably the gastric hormones have something to do with this, because they're increasingly being used in the treatment, but we don't clearly know what are the associations between these gastric hormones and obstructive sleep apnea.
So I think that's very well explained about the non-structural as well as the endocrine factors. Dr. Murli also mentioned about sedatives. I'd like to go back to Dr. Aakanksha. Can you tell us, explain a little bit more in detail about how the use of sedatives affect obstructive sleep apnea?
Sorry. So, sir, I would like to emphasize here that sedatives are highly contraindicated, should be avoided as much as possible.
Yes.
These patients, they should not even be thought of. However, if they are taken, the consequences would be that there would be prolonged apnea episodes. There would be a delayed ventilatory problem. There would be a prolonged time to arousal, ultimately resulting in catastrophic events and the complications that we're talking about, majorly the cardiovascular or the strokes and other things, because there's going to be a prolonged hypoxia, which we've been discussing and we are going to be discussing. So I think sedatives is something which should be not used as much as possible, and should be very well thought of, and should be very closely monitored if at all they have to be used in certain situations.
Yeah, so I
Prashant, can
think
I
that is
just
so.
add a little to that with your
Yes,
permission?
yes, yes.
So the first
Please.
patient of obstructive sleep apnea I picked up was somebody who went into a prolonged apnea, became purple in the face after receiving sedation for bronchoscopy, needed an urgent intubation. And we see this very commonly in the post-op recovery phase when they extubate them and then they manifest the signs. So that's one place where we pick up these patients. So emphasizing what Dr. Aakanksha said, sedatives are contraindicated. Where they are necessarily have to be used as in a operative situation, you need to monitor these patients very carefully as you take them off sedation.
Yes, and Murli, now just to take that a little bit forward, I think we diagnose high risk individuals for sleep apnea in the bronchoscopy room almost on a regular basis. You give a little bit of midazolam, you give a little bit of propofol, and there they start to get hypoxic. Some of them with a little bit of midazolam will already start to snore and then go probably into upper airway obstruction. Just where we published a paper, almost in Chetal almost 2 decades ago now, that if you are having an individual, I know it's a bit off track, but if you mentioned bronchoscopy, you mentioned this hypoxemia and the need for intubation, we've shown in more than 700 procedures that if there is a hypoxemia which is happening during bronchoscopy, in 88% of those patients is because of sedation, and you put in a nasopharyngeal tube and that reverses hypoxemia. But okay, so that's a different discussion. So now let's move on to the physical examination findings in individuals having sleep apnea. And here I've got questions in 2 parts. The first part question I would like to ask Dr. Girija about what are the typical examination findings that you come across in a patient with sleep apnea. And the next, important Malapati scoring is something which I'm going to refer to Dr. Aruna following that. So Dr. Girija, if you can just tell us briefly about the physical findings.
Yeah, so even when you see the patient, they come with breathlessness or they come with this sleep problem, you look at him and then you see, oh, his BMI is high. So one thing is commonly is obesity, so with a high BMI. But like Dr. Murli Mohan said, there are about 10 to 20% of people who may have a normal BMI. But generally, obesity is the one thing that, that is there with a higher BMI. The next thing that we look for is neck circumference of these patients. They have as we said, there's an upper airway obstruction. So usually the neck circumference is more, about 16 inches in women, more than 16 and 17 inches in men is considered as a higher neck circumference, which will go for our stop bang, points, which comes to around 37 and 42 in men. So we have to measure the neck circumference, which will be increased. Then the oral upper respiratory tract, we can look for some either DNS or the oral cavity, especially what we look for is retrognathia and airway obstruction, airway blocking. The tongue is thick, hypoglossia, what we call as high arched palate may be there. The palate may be coming down, that is more. Nasal deformities may be there, septal defects may be there. The thyroid may be enlarged. That is one very important thing that we should look for in this for the general examination. Other things like we have to look for hypertension and then cardiac abnormalities like atrial fibrillation, history of or stroke, myocardial infarction, pulmonary hypertension, and heart failure. Again, we should be looking for that in these patients on our examination. Saturation, of course, very often their saturation may be normal or it may be reduced because they usually have intermittent hypoxia. Maybe at night they are going into hypoxia. In the daytime, they may not be desaturating. So these are the few general examination findings we should be looking for and expecting in these patients of obstructive sleep apnea.
Perfect, madam. Thank you so much for that. And just to take a point forward on that, madam mentioned about oxygen saturation in an obese individual. If that individual has hypoxemia at presentation, there are 2 things we must look for. One is obesity hypoventilation syndrome, and then you must look for an arterial blood gas, or whether that individual also has an associated lung, a severe airway disease, or any other disease which is also contributing to the hypoxemia. So, ma'am, now to come to Dr. Aruna, can you just explain to us the Malampati scoring system and its association with sleep apnea?
Yes, this Malampati score is actually a very useful bedside tool which we can use to predict the risk of patients who are going to have an obstructive sleep apnea. So basically, the score was mainly designed to predict the risk of difficult intubation, but this is also being used to predict the risk of assessing the OSA. That is by visualizing the soft tissue or the oropharyngeal structures when asking the patient to open their mouth and protrude the tongue. There is actually a modified Malampati score, also known as the Friedman score, but it's almost the same. It's just that the patient is asked to open the mouth. So there are it has been shown in studies that the class 3, there are basically 4 classes, class 1 to 4. So in the class 1, we see the anatomy of the oropharyngeal structures, wherein the soft palate, the uvula, and the fascial pillars, that's the tonsils, are very clearly visualized. In the class 2 grade of Malampati, the soft palate and only the base of the uvula and the tonsils are hardly visualized. Moving on to the higher grades, and the grade 3, you hardly see the even the uvula, but in the grade 4, only the hard palate is seen. So the class 3 and 4 are the predictors of having a higher risk of a OSA. And it's shown that as the Malampati grade or the scale increases, there is a 2-fold odds of having an OSA. But we generally don't use it as a diagnostic tool for OSA. We use it as an adjunctive or a supportive tool in supporting the diagnosis of OSA.
Yes, and I think I think I agree with you. Malampati score is very important. It helps us in the assessment of the patient for the contributes to the pre-test probability. But for the pre-test probability of obstructive sleep apnea before you subject them to a polysomnography. But I think there's one more important thing is that if we put Malampati score in our in our SOP, then we are going to examine the oral cavity. And, from time to time, it's not unusual to find an adult with big tonsils. Okay. So I think in that case, the game completely changes. It's not very common, but we see them on time to time. And therefore, it's extremely important to examine the oral cavity in detail, not only in children, but also in adults. So now, I would like to come to Dr. Kripesh. Patients have symptoms of nocturnal enuresis. Patients have morning headaches. They have saliva dribbling down, in the mornings. And often, our residents will ask, or even the patients will ask, "Kyun hota hai?" So can you just explain to us the mechanisms behind this?
Yeah, yes, sir. So basically, what happened during the obstructive event for nocturnal enuresis, there's a pressure-induced nocturnal enuresis. Basically, what happened, there is an increased secretion of active natriuretic peptides, and this occur basically because of the obstructive event. This leading to your salt and water retention and increased excessive urine production at the night time. Secondly, there is also because of a disruption of the sleep that also potentially affect the bladder ability to regulate urine production and bladder control. And these are the two mechanisms through which there are possibility the nocturnal enuresis occur in OSA patient. Then morning headaches mostly occur basically of two possible mechanisms. There is a cerebral vasodilation, which is basically induced by the hypoxia during apnea attacks, and which cause a vasodilation and cause morning headache. And secondly, there is a sleep fragmentation also, which disrupt the sleep architecture and likely to cause morning headache. And then if you go for the dry mouth, basically most of these OSA, these are mouth breather, and because of the mouth breathing, and also there is a disruption in the salivary gland function. There's an increased salivary gland secretion that will cause dribbling of saliva, and also because of the mouth breathing, there's a dryness in the mouth. These are the basic mechanism behind this different presentation of OSA.
So I think it's so simply explained, Dr. Kripesh. Thank you so much for that. Explain the mechanisms behind the symptoms, and the minute you talk about these mechanisms, somehow it really helps us the understanding better and a resolve towards sleep apnea better. So now moving a little bit further from the mechanisms, what you said, I'd like to come to Dr. Aakanksha. Dr. Murli Mohan did refer to the neurological problems that a sleep apnea patient can face. But I would like to request you to, if you can just a bit expand on the neurological complications of obstructive sleep apnea?
So, sir, we've been talking about the obstructive sleep apnea. We know that there is chronic intermittent hypoxia, there is fragmentation of sleep, which leads to neuronal apoptosis. It also leads to impaired neurotransmitter balance. Commonly, there is a cognitive dysfunction, which you would often see the relatives or the patient complaining that there is impaired attention, there is frequent memory deficits, memory loss. The patient becomes more forgetful, is not attentive, one of the most common presentations which you would see. Then there are mood disorders, as Murli Mohan sir quite nicely elaborated it during his talk, that a psychiatrist knows that if you would give CPAP to his patient, it would be better. These patients have a lot of anxiety and depression. And when this is combined with excessive daytime sleepiness and fatigue, it's often ignored. It is often overlooked. And this is another problem with this with the OSA patients. Then there is increased risk of stroke, both the first as well as the recurrent stroke. We've been talking about mechanisms of blood pressure surges, endothelial dysfunction, arrhythmias. So these patients are much higher at a higher risk for developing strokes. And then because of this hypoxia and sleep fragmentation, the seizure threshold is lowered. So treating these patients with actually improves their seizure threshold, especially in patients who have drug-resistant epilepsies as well.
Yeah, so I think, thanks a lot, Aakanksha, for that. And, clearly, again, to reemphasize that in individual with sleep apnea who had a stroke, and if you don't treat them, then there were higher chance of getting the second stroke. So I think that's something very important. So now, I would like to come again to Dr. Murli. Murli, you mentioned about the cardiac problems associated with individuals having sleep apnea. So again, I would like to just request you give some key messages on that. And there are some questions from the audience also, if I may just push them also towards you, is what are the incidence of CKD and renal artery resistance in case of OSA with hypertension, diabetes, without any other cause of CKD? So if I may request you to combine both of them.
So the cardiac problems first. Coronary artery disease in all its manifestations, stable angina, unstable angina, going on to major adverse cardiac events, well known to be associated with the OSA, and hopefully reversing when you treat them with CPAP. Unexplained heart failure, dilated cardiomyopathy, extremely common. And if a person has dilated cardiomyopathy and comes to us with the cardiologist saying normal coronaries when I did his coronary angiogram, always look for evidence of obstructive sleep apnea, and you'll find it surprisingly common. Systemic hypertension I've already referred to, especially if it's refractory. Pulmonary hypertension, the other risk factor. But a large number of patients come to you with arrhythmias, and these arrhythmias can lead to stroke, which Dr. Aakanksha has referred to, and atrial fibrillation is prime among them. So almost 50% of patients who have atrial fibrillation present with stroke, and vice versa. If you catch a person with stroke and you do, especially a young person, so that's the other group that you'll find with atrial fibrillation very commonly among them. Remember that the atrial fibrillation is not continuous. These patients have paroxysmal atrial fibrillation. So, you'll have to monitor them either with a Holter or a loop recorder, event recorder. But more and more these days, patients come and tell me, my smartwatch has told me that I have atrial fibrillation episodes. And this is particularly among patients with sleep apnea who are not using their CPAP. So, modern technology is very useful. So this is the range of cardiovascular problems. And I'm not spoken about peripheral vascular disease, which again is probably associated with OSA, again as a part of the, obesity, atherosclerosis, endothelial dysfunction, platelet stickiness that is driven by this systemic inflammation. So they also tend to have a higher problems with peripheral vascular disease. But because there's an overlap with diabetes, this leads to, confusion whether it's the diabetes that's causing the diabetic foot, or is it OSA, or are both contributing. So I think we have a role to play to work with the vascular surgeons. Sorry, the other question was on
renals.
Renals. Yeah. So chronic kidney disease well associated with obstructive sleep apnea, whether it's driven directly by the hypoxia that affects the kidney, or more likely the endothelial changes. After all, the glomerular tuft is one of the biggest sources of, thickest concentrations of endothelium, or whether it's the hypertension that accompanies these patients. Very difficult to tease out these different things, but definitely OSA is associated with CKD. And the problem is CKD patients, because they retain salt and water, tend to have more upper airway obstruction once they go into renal failure. So it works bidirectionally.
Yeah, so I think that's also very well explained. So actually, if you see, as the data is emerging, we have sleep apnea associations data coming up associated with as a contributing factor to several chronic diseases in a multi-system manner. And I must say that from time to time, when we diagnose and treat these individuals, you often see in several patients there's an improvement in the renal function. We see the serum creatinine go down in several patients, and that can be very, very satisfying to see. And I think, and that also helps in our cross-specialty management of patients as well. So moving forwards, now that we've discussed these multiple system involvements as far as sleep apnea is concerned, I would like to come to Dr. Girija and ask you, Madam, what are the complications, metabolic complications of untreated sleep apnea, and what is the syndrome Z?
Yeah, I'll just go to syndrome Z first. Syndrome Z includes metabolic syndrome, which is syndrome X, what we say, and obstructive sleep apnea. So when obstructive sleep apnea is associated with metabolic syndrome or syndrome X, we usually call it syndrome Z. So what is metabolic syndrome? And in fact, all the metabolic complications of untreated OSA, I would at least call them, there are four if we can put it in short. One is the increased risk of metabolic syndrome. One is insulin resistance, which is part of that, and type 2 diabetes, which we put it as separately. And at least the fourth one, I would call it as a NAFLD, or the non-alcoholic fatty liver disease. So we could call it as metabolic syndrome, then insulin resistance, then diabetes type 2 diabetes mellitus, and NAFLD. So basically, what we have is that OSA is associated with an increased risk of metabolic syndrome, which is having a higher cardiovascular, one of the risk factors. So there are animal models as well as studies have also been done. And basically, like Dr. Sir has already mentioned, Murli Mohan has already mentioned those metabolic factors, but and the mechanisms by which they are acting. The main thing is intermittent hypoxia. So intermittent hypoxia is the one that causes a lot of insulin resistance. It is known to cause that. And even obesity, it is known to cause obesity, OSA with insulin resistance, because in OSA there is sleep fragmentation. Even sleep fragmentation itself, it can independently affect the glucose metabolism. And sleep fragmentation, it also interrupts the normal secretion of growth hormones. So, which is, it also stimulates the hepatic production of insulin-like growth factor 1, and which promotes the sensitization. So what happens is there is association of OSA with glucose tolerance. What is the association? Is that OSA is an independent risk factor for diabetes mellitus, and there have been studies where the IR, insulin resistance, has been calculated, and they have found that the degree of insulin resistance is with higher degree of insulin resistance is been associated with OSA. So OSA patients have a very higher degree of insulin resistance, and therefore the diabetes mellitus also. Now, what is metabolic syndrome? If we think about it, it is related with there is systemic hypertension, dyslipidemia, where there is higher LDL and lower HDL. And it is also associated with abdominal obesity and, of course, high blood sugar levels. Fasting more than about 110 is what is the definition of a metabolic syndrome. So the complications are now, there have been various studies also. So insulin resistance is associated with obesity, and the association of there is severity of nocturnal hypoxemia is associated with a higher insulin resistance. So this basic, as doctor said, that nocturnal intermittent hypoxemia is the one that causes major problems to the patient, and that is a main mechanism where all these metabolic complications occur. Dyslipidemia, also studies have been there that even in children with OSA, when they have removed their tonsils, it has been found that their cholesterol levels have come down. Similarly, treatment with CPAP has again brought the cholesterol levels, LDL, down. So the treatment itself, by giving CPAP to our patients, and at least minimum, like doctor said, 4 hours of CPAP is enough even to bring the levels of insulin resistance down. So these are the various studies that have been done and the various metabolic problems that are there. And the other one is also higher levels of transaminases have been found in patients of OSA. So maybe there is a liver, there is a tissue damage because of hypoxia that is causing this liver early damage like steatosis, or leading to the larger damage like NAFLD and liver cirrhosis, which is there. It could be a part of the whole what you can say spectrum of disease that can happen directly because of OSA, also maybe because of the tissue damage which due to the hypoxia. Or oxidative stress is the other thing that is the major mechanism which is causing the liver NAFLD that can be there. So metabolic syndrome, insulin resistance, diabetes, and NAFLD, these are the 3 or 4 different metabolic basic problems that can occur in OSA, in the patients or subjects having OSA.
Thank you so much, Dr. Girija. I mean, I must thank all the faculty, the panelists, and also Murli for his speech which is given. I think this is just an amazing masterclass for the entire audience and for me as well to learn so much about sleep apnea in such a short time. One more thing I would like to highlight is, the amount of metabolic syndrome I think we see in our country is large. And if we identify these patients and you diagnose it and you treat the sleep apnea with PAP therapy and you follow them up, I think then that also increases our resolve to treat these patients better. Because like you clearly said, you see improvement in transaminitis, you see improvement in dyslipidemia, you see an improvement in the sugar levels, in the insulin resistance. So I think sleep apnea, as highlighted in this particular ongoing session, is a systemic, is a disease with a lot of systemic implications. Okay, and one more systemic implication that now I would like to bring Dr. Aruna into the discussion is about the association of obstructive sleep apnea with pulmonary hypertensions. And after that, if you can also allude to the pulmonary complications associated with sleep apnea and the overlap syndrome.
Okay. So first, let me start with the pulmonary hypertension. As you have highlighted, is a very important systemic manifestation of OSA. And as Dr. Murli Mohan has said earlier, the type of pulmonary hypertension is a combination of a group 2 and 3. So these two, both a pre and a post capillary component is involved. And in OSA patients, almost 20 to 40% of these patients are found to have a pulmonary hypertension, though it is in the mild to the moderate range. Suppose the pulmonary hypertension is out of proportion to the OSA, in the absence of lung disease or any other etiology, then probably we have to consider other chronic lung diseases which are associated with the pulmonary hypertension. Now, pulmonary hypertension occurring in OSA is a complex and multifactorial process because there are multiple factors which are contributing to the development of pulmonary hypertension in OSA. Right from intermittent hypoxia, we have sympathetic hyperactivity and the endothelial dysfunction. These are the 3 major contributing factors. Another important factor we have to remember is the intermittent hypoxia. What it does is it increases the pulmonary vasoconstriction happens, so the pulmonary vascular resistance happens. And the increasing amount of negative intrathoracic pressure, it can go up even to as much as minus 80 centimeter of water also it can go if the upper airway resistance is very high. So in these conditions, what happens is because of the increased negative intrathoracic pressure, the venous return increases, the RV preload increases. So because the RV preload increases, and also there is an RV afterload because of the increasing pulmonary vascular resistance. So all these factors cause a RV hypertrophy, and at many times in the echo finding also we see that there is a herniation of the septum, the interventricular septum into the LV. So this again causes an LV dysfunction. So there is a combination of a pre and a post capillary component to the pulmonary hypertension. So I feel in all the cases of pulmonary hypertension, a sleep disordered breathing etiology has to be considered when there are risk factors for OSA. Because many a times, of course, we have other factors, primary and secondary pulmonary hypertension, but it is to be considered that the SDB, especially OSA, should be considered in the differential when we work up a case of pulmonary hypertension. Now, moving on to the next part of your question, sir, regarding the pulmonary complications of OSA. Of course, pulmonary hypertension is a complication. Apart from that, this OSA also worsens coexisting or chronic respiratory diseases, whether it is a COPD or an interstitial lung disease or an asthma COPD overlap. It does lead to worsening of the underlying lung disease. It also causes respiratory failure. It can lead to, and because of the immune dysregulation, it can cause a lot of pneumonia, and pulmonary infections are also on the rise. And as very well said by you in your earlier talk as to the incidence of bronchoscopy-induced hypoxia. There is also a very important perioperative or intraoperative complication that OSA can. So undiagnosed OSA patients going in for surgery. Usually the bariatric surgery patients are evaluated earlier, but many of them go into surgery without a diagnosis of OSA, and then they land up, one is either a difficult intubation pre-surgery, or they take a longer time to extubate the patient, or they are extubated on NIV. So these are some of the complications, sir. And the last part of your question regarding the overlap syndrome. So this overlap syndrome, the term was coined by Flenley in 1985, and it is actually referred to a combination of the presence of a COPD and an OSA together. Now, why is this overlap syndrome so important clinically? Because it leads to a significant nocturnal desaturation in these patients, and there is a bidirectional link between OSA and COPD. So in COPD, there are certain factors which predispose to the prevalence of OSA. For example, as sir had earlier said, in a heart failure or cor pulmonale, when the patient is supine, there is a rostral shift of the fluid. So this increases the airway, upper airway edema, leading to upper airway resistance. And the common etiological factors like smoking and obesity. So these are both the contributing factor for both these conditions, sir. And an important finding in COPD patients who have done a nocturnal oximetry finding is the appearance of the sawtooth pattern. This is a typical appearance in a COPD patient who has a risk of developing or a risk of OSA. We can suspect even before we go for a PSG if they have, because the screening questionnaires which you administer when there is a coexistence, studies have shown that it's not very useful because the symptoms usually overlap. So the sawtooth pattern, that is a rapid discrete desaturations, are extremely important in picking up these overlap syndromes. And the addressal of this overlap by treatment with the CPAP. Mm-hmm. So instead of just giving nocturnal oxygen, which may worsen the nocturnal desaturation, we have to start the NIV, the CPAP, and then address the issue. And whenever this overlap syndrome is one of the DDs for OSA with daytime hypercapnia. The other differential is the obesity hypoventilation syndrome, what we call as a Pickwickian syndrome. So when an OSA patient has we find a morbid obesity, I think we have to do ABG to rule out awake hypoventilation, daytime hypoventilation, to pick up these hypercapnic patients, because their management will be slightly different.
Perfect. So I think that's a very good overview on this. I mean, this is actually a lecture by itself. We can also talk about pulmonary embolism. The pulmonary embolism is also associated. We know that, the mechanism is the same. Increased coagulability of the blood, again, causing the risk for pulmonary embolism. Madam, there's one question from the audience from our friend Pramod from Ajmer. He would like to ask, when we know that pulmonary hypertension and sleep apnea, coexist as known. What percentage of these patients would need? Is there a role of any pulmonary vasodilators in this group of patients?
Yes, sir. So specifically because it is a basically secondary to the OSA hypoxia. So before coming to the PAH specific therapies, I think we should address the primary problem. Because unless that is, we have to give the NIV, we have to treat the other treatable traits which are there. And then because it's under guideline, this one, there is no role for a specific PH therapy in this type of patients. Probably in other lung conditions like pulmonary fibrosis and ILD, there is a role of certain PH specific therapies which are under studies. But as of such, we address the primary issues.
Yes, so I agree with you. I think the role, the sleep apnea we know is associated with pulmonary hypertension, and you treat sleep apnea, and if sleep apnea in all the cases where sleep apnea is contributing dominantly to the pulmonary hypertension, you can see the pulmonary hypertension getting better. Obesity is also a contribution as far as pulmonary hypertension is concerned. And, to take, I would also like to bring in again Murli, there's Parvez is asking, a question about is there a role of semaglutide and tirzepatide in the treatment of sleep apnea? You referred to this, and therefore, Murli, if you can just expand on this.
Yeah, so the recent trial, the Sarmah trial, used tirzepatide in obstructive sleep apnea. These were all obese patients with sleep apnea. And there was a very nice correlation between the drop in weight and the drop in the AHI. This was a parallel group study. They did both. Both groups showed almost identical data. Weight comes down, AHI comes down. So one of the lead authors, Dr. Atul Malhotra, now claims that the treatment for sleep apnea should be tirzepatide. I think studies are on for the other GLP-1 things like semaglutide. We don't still have the study results as far as I know. But even when you just look at obesity, tirzepatide seems to outperform semaglutide. So the long and short, yes, there is a role for these medicines. They are trying various other medicines. So there are, watch the space. Medical pharmacotherapies may come in, but at this point in time, I still think CPAP is the cornerstone of all treatment.
Yes, and if I can add to that, Murli, a little bit, from your experience, we have a small number of individuals who do lose weight. A large number don't lose weight, at least in my practice, but some number of patients do lose weight. And, I think a lot of them continue to the need to use the CPAP. So there are very few patients in whom we have seen that, the CPAP goes away. The CPAP does go away in those individuals with, who have a disproportionately high obesity and a mild sleep apnea, or a mild to moderate sleep apnea. I think the chances of the CPAP going away is high there. But I think in those individuals who have a severe sleep apnea and obesity, I think even if you bring down the weight, I think the sleep apnea continues. The point I'm trying to bring across is I think it's really important to watch this space and follow these patients with weight loss, which we are going to get with pharmacotherapy for a prolonged period of time, and see, what is the impact on sleep apnea, which categories of patients will benefit with pharmacotherapy for obesity. And, we should not already start giving patients the hope that, if you take these expensive pharmacotherapies, then, the CPAP may go away. I don't think that we are in to promise that to our patients. Yeah?
Absolutely. Completely agree.
Hello?
Yeah, completely agree with what you said.
We lost you? Yeah, anyway, so let's move on to the next topic. I think this discussion gets more and more interesting. And Murli did mention to us about, and the other panelists did mention about the autonomic nervous system, the way it gets affected. And I would like to bring in Dr. Kripesh, again, who can just explain a little bit more about how OSA affects the autonomic nervous system and what are the clinical implications of that.
Yes, sir. It is very interesting things, because nowadays some newer devices for diagnosis of sleep apnea can give an idea about the autonomic dysfunction, either the patient's systemic, sympathetic, or parasympathetic is more active. So they give an idea. So these new devices, so we can have more in future, a more important role of this autonomic nervous system in OSA. So in OSA, basically there are two things happen. There is a systemic overactivity and there is a parasympathetic dysfunction. So why this happen? Because there is during OSA, there is an event of hypoxia, there is an event of hypercapnia, and there is a arousal. So this lead to a sympathetic nervous system overactivation, which lead to increased heart rate. This increased change blood pressure rises, and there is a release of stress hormones. So this chronic overactivity can contribute to the hypertension or major cardiovascular risk factor. Also, there is a parasympathetic dysfunction, though this because the OSA disrupt the normal balance of the autonomic nervous system with reduced parasympathetic activity during the night, and this can lead to your impaired heart rate variability, which is a measure of the autonomic nervous system ability to adapt to the changing condition. So all this autonomic nervous system dysregulation basically lead to your cardiovascular can lead to a clinical implication like your cardiovascular diseases. So this increased autonomic dysfunction is significantly associated with increased cardiovascular risks like your hypertension, coronary artery disease, or arrhythmias. There is also clinically increased risk of diabetes mellitus when there is autonomic dysregulation, including particularly through your impaired glucose metabolism and insulin sensitivity. And other health problem because of this autonomic dysfunction is your gastrointestinal motility will be affected, urinary function will be affected, and there is also sexual dysfunction, which has been reported associated with autonomic dysfunction in OSA patients.
So I think that's also very well explained. So as we go into more deep into sleep apnea, I think we clearly start to see the multi-system affection that sleep apnea can cause. So now the vascular issues have been referred to in a cardiac manner, peripheral vascular issue. I briefly mentioned about pulmonary embolism. Dr. Aakanksha, could you just briefly summarize the vascular complications of untreated sleep apnea?
So we know that untreated OSA leads to intermittent hypoxia, repeated arousals, large intrathoracic pressure swings during apneas. So we've been talking about the sympathetic nervous system overdrive, oxidative stress, endothelial dysfunction, systemic inflammation, as well as the increased platelet aggravability. All this together leads to the major vascular complications, systemic hypertension. Now, OSA remains an independent risk factor for resistant hypertension. Murli sir mentioned during his talk as well, the loss of nocturnal dipping pattern is a hallmark in these patients. Then pulmonary hypertension is something which has been explained by ma'am. Atherosclerosis, in fact, there is accelerated atherosclerosis which is seen in coronary as well as the carotid atherosclerosis in younger individuals as well. Then higher risk of both ischemic and hemorrhagic strokes. Increased cardiovascular mortality, so more higher risk for myocardial infarction, sudden cardiac death. Overall cardiovascular mortality increases in these patients. You mentioned about pulmonary embolism as well. Again, these patients become at a higher risk for these conditions. So overall, these remain the vascular complications in these patients.
So I think that's well summed up as far as the vascular complications associated with sleep apnea concerned. And now, I'd like to ask Murli one more question before we go on to the audience questions. I think the audience questions will take as a rapid fire. I think it's worthwhile because, we've got almost 2,000 people who've joined in and who are still online, and we need to be fair and answer as many questions as possible. So, again, I'd say obstructive sleep apnea, we're talking about multi-system involvement as a systemic disease. So Murli, can you just briefly touch upon the development of systemic inflammatory conditions and immune dysfunction related to sleep apnea?
Yeah, so just like in COPD, we have systemic inflammation. In fact, I like this term that we should stop calling it COPD. We should call it chronic systemic inflammatory syndrome. And it lies on this spectrum. OSA also has definitely high systemic inflammation. Some people have used a marker called the systemic inflammatory index, which looks at the neutrophil lymphocyte ratio and associated with the platelets. So you have neutrophils, platelets, and the lymphocytes, and you have very high levels of inflammation indicated by these. There are also good studies showing that other inflammatory markers are raised. Paradoxically, some of the inflammatory markers like IL-6, interleukin-6 are low, and this is thought to be the immune dysfunction that happens with them. So on the one hand, you have systemic inflammation. It is driven by the hypoxia, by the oxidative stress that happens. Sandeep Salve is one of those who loves to talk about oxidative stress. So, that is one of those very definite things that you can measure, that oxidative stress are high, reactive oxygen species are high. So undoubtedly, systemic inflammation drives many of the conditions. On the other hand, you have immune dysfunction. Now, again, they've shown that various different immune cells, T cells, B cells, natural killer cells, dendritic cells, all seem to be dysfunctional in patients with severe OSA. Unfortunately, all these studies are very small. Most of them are lab-based and have not really come into the bedside. But I think we should be aware that, I think Madam mentioned this, Dr. Girija mentioned this, that there is a greater risk of infections in patients who have obstructive sleep apnea, especially recurrent respiratory infections, upper respiratory infections, very, very common. And many of these actually reverse when you start them on CPAP. So yes, there is immune dysfunction, there is systemic inflammation, and these contribute to the underlying pathologies that drive this condition.
So I think that's amazing. I think, I think there's so much to learn about sleep apnea. There's so much to talk to our colleagues about sleep apnea in different specialties. And I think, this could be a good topic for conversation whenever we have coffee with our colleagues, okay, just to expand the awareness. Now, let's move on to the questions that have come up in the chat box. A lot of these questions have already been addressed by our panelists. But, nevertheless, I'm going to go step by step and, and cover as, make sure that all are covered. One question is about is pharmacotherapy considered as a non-PAP therapy for CPAP? I think we already mentioned about tirzepatide, and that there is new pharmacotherapy for obesity coming, which can have an impact on the CPAP, on CPAP, or on the treatment of OSA. And I think that we still need to wait for the longer term results. What about depression? Yes, depression and the psychiatry, as Dr. Murli mentioned, there's a strong association between psychiatric conditions as well as sleep apnea, and that is something which we need to look at. I must also say that we have a lot of psychiatric colleagues, several psychiatric colleagues who are sending us patients when they identify that there are some things like depression, obesity, snoring. So the contribution of sleep apnea is being recognized more and more. And now, again, that one question is coming from Shillong. Can we start CPAP therapy in a patient with a high possibility of OSA? The answer is clearly no. We need to do a polysomnogram. We need to evaluate the patient completely before we initiate the treatment for sleep apnea. Then the next question is about at what is about insulinperidol low. Then the next question is, in the recent past 10 years or so, OSA has become a very discussed topic. Is it due to the increased awareness, or actually the cases of OSA increasing due to increase of obesity? I think, Amitabh, both the points are valid. I think we are still got the low-lying fruits. We're still plucking the low-lying fruits. We still not reached the top, like Australia has reached for that matter. So yes, I think the awareness is increasing. We are diagnosing sleep apnea more and more, and at the same time, as you mentioned, there is an increased obesity. And we mentioned that almost a third of the Indian population is estimated. I don't ask me for the quote, but this is again from attending various conferences. Almost a third of Indian population may be obese. So yes, both the points are valid. Then the next question is, Murli, there's a question, if you can take this. How do you diagnose complex sleep apnea, and how do you treat complex sleep apnea?
So complex sleep apnea, or better called treatment emergent sleep apnea, is CPAP. You start treatment. A person who previously had predominantly obstructive sleep apnea now starts showing that there's more than 50% central sleep apneas. So basically what you have to do is you diagnose it, you put the person on treatment and review. Seems to be much more common in patients who have heart failure. I've seen most of my patients with TEXA or complex sleep apnea have this. So what you may need to do, and this is a matter of controversy, is put them on ASV, adaptive servo ventilation. The problem with ASV is the one large trial showed that there was an increased mortality. But you break them down into two groups, those who have a ejection fraction of less than 45% and those with more than 45%. The ones with better ejection fractions do well. The ones with worse ejection fractions do badly. We're not very sure why this is, but definitely mortality is higher. And then you've got to primarily look at correcting their cardiac issues and then think whether you can reintroduce, the adaptive servo ventilation.
Perfect. So that's thank you, Murli, for that. The next question is about we don't see patients coming to OPD for OSA evaluation. So shall we screen patients? Yes, I think screening of patients can be done at health checkups or at camps, whatever method you want to do. Stop band questionnaire is a very useful tool for sleep apnea. Also, the EPO sleepiness scale is also important to identify patients. There are other questions, there's Berlin questionnaire. So you can see whatever suits you best in your setting, how you can implement screening. I think that's good. Children, we've covered. Now, Aakanksha, do you want to take this? How to treat persistent daytime sleepiness even after CPAP compliance?
So sorry, I didn't get the question. How to?
How to treat persistent daytime sleepiness even after CPAP compliance. Aakanksha or anybody who wants to take this.
Sleep hygiene is something which we often recommend to the patients, which should be reinforced. Something which is
yes.
PAP therapy remains a very important aspect of treating your OSA patient. There are drugs like modafinil which are used, but I think that is only very supportive. Reinforcing sleep hygiene, telling them about their liquid intake, avoiding caffeine, and everything that forms the sleep hygiene is another very important aspect, which can naturally is going to make a dramatic difference in the excessive daytime sleepiness.
And manage thyroid and other diseases, You check for the thyroid and manage that also. Sometimes many of them have hypothyroidism. So I suppose treat that also along with this, So look for other causes also for the daytime sleepiness, That is what.
Perfect. There's another question which has come about the prevalence in drivers. I think there are several countries where this has evolved in a big way, particularly in Australia, in Europe, and other Western countries, where if there is a professional truck driver, who has met with an accident, turns out to have obesity or a high BMI, has to undergo a diagnosis for sleep apnea. If that individual has a diagnosis of sleep apnea, that individual needs to take treatment for that. The treatment has to be documented, and only then that individual can come back to work. So yes, I think in drivers, professional drivers, it's really important. We slowly start to see within pilots that it is where it is getting more and more important. And I think that this is again something I'm not aware of any Indian data as far as drivers is concerned. If anybody has data, please, please you can share it. But I think it's something which definitely needs much more awareness, and we need to talk about it more and more. The next question is about young individuals, only with snoring and no excessive daytime sleepiness and no comorbidities. What to be done? Dr. Aruna, you want to take that, please?
Yes, sir. This is actually what we were talking about as a primary snoring or the simple snoring. Of course, these patients do need to be followed up, in view of the risk factors like increasing weight or cardiac comorbidities with snoring. So these subset of patients need to be followed up carefully. But of course, it is not indicated in all snorers. So how do you actually come to a conclusion whether to do a PSG for a snorer? So rule out any other treatable causes like upper airway conditions, or address the lifestyle measures like the weight, or advise posture, the positional. So we have the phenotypes of OSA like the REM and postural OSA. So you advise those. But in spite of these, if the patient has a perpetual or a habitual snoring and in the presence of additional risk factors, yes, we can go ahead and evaluate them with a form PSG.
Perfect. So I think that's also very well explained. Thank you very much. And Dr. Kripesh, if we can bring you in for the next question, what are the indications of bi-level NIV in OSA?
Yeah, definitely. So there are a few indications where we can go for a bi-level or BiPAP basically in place of a CPAP. So first one is that if the severity is high and patient require a very high CPAP pressure, where patient cannot tolerate the CPAP pressure, then that is one thing. Then another is if the patient has associated COPD problem, in that case, again, in place of a CPAP, bi-level pressure will be a more useful modalities for treating OSA.
So perfect. Thanks a lot. There's the other question is maybe I can bring Murli in. Well, would you go with just using an auto CPAP or a CPAP titration once you've made a diagnosis of sleep apnea?
The difficult question to answer because what is recommended is titration studies. It doubles the cost.
Yes.
That's the problem. If you can do a split night titration, you may not get very accurate values because OSA gets even worse at night. But what is recommended is titration followed by manual CPAP. In actual practice, I find that an auto CPAP works, equally well. There is no advantage to using an auto CPAP except convenience and the fact that you don't have to spend on another sleep study, this time for titration. So long and short, no difference between the two. Choose according to your individual patient. Patient cannot afford an auto CPAP. I'd be very happy to do a brief early split night titration and advise a manual CPAP.
Yes, and just to highlight here that a split night titration is something is an attended study. I mean, often we see that at home studies half the time polygraphy is done, a limited channel study, and half of the time the CPAP is put in without a diagnosis being made. I think that is something which we should avoid if we want to take this specialty ahead. Then we need to do it systematically. If a split night study there is typically an in-lab study, an in-lab study is the best way, in my view, to do a split night study. And the technician doing the first half of the study also needs to be well trained and adept to making a confident diagnosis of sleep apnea based on whatever the teachings are, and then maybe a short call, or if you're confident the patient can the technician can go ahead and do titration and combine it with split night. So the reason I bring this up is I think let's not make too many shortcuts and too many things where the accurate diagnosis is compromised as far as the patient is concerned. And one more argument, of course, if somebody's got a mild sleep apnea with symptoms, mild sleep apnea you might observe, but you've got a mild sleep apnea with symptoms, can be easily treated with a CPAP trial, etc. Yes, we can keep on discussing that. But mind you, my take on this is whenever we're talking about sleep apnea, we're talking about a disease where the treatment is going to go on for long. So I think we must not miss an opportunity unless there are circumstances where you need to take a clinical decision, move forward. We must not miss the clinical opportunity to do a systematic diagnostic and a titration study. Of course, this needs to be decided on a case-to-case basis. Next question is about Next question is about musculoskeletal system. We covered that. Systemic inflammation was also covered. Now the question is, how sensitive is BNP in OSA cases? Many times we see that BNP is normal when CT shows signs of congestion. I think, the role of BNP in sleep apnea is only in those individuals who have cardiac failure. I think, if you have, I think there's no direct correlation of BNP with sleep apnea, but yes, if there's sleep apnea plus cardiac failure, you can, the BNP definitely has a role. If you have an individual who has got symptoms of cardiac failure and our routine 2D echo comes and says, oh, there's an EF of 55, 60%, that's normal, then we already mentioned that's cardiac failure with preserved ejection fraction where the NT-proBNP is helpful. So I think that's what we've discussed already. We have patients with metabolic syndrome, dyslipidemia. That's been discussed very well. I'm sorry, I'm just scrolling as I talk. There are lots of questions. And I think there's this question about refractory hypertension and comorbidity of diabetes can also cause kidney disease. So what came first? And I think An important thing when we talk about sleep apnea is its contribution. It may not be the sole reason for a particular comorbidity or a morbidity, but it can, yes, sometimes it can be the sole reason. You have a young hypertensive who's obese, who has no other risk factors. You treat the diagnose of sleep apnea, you treat the sleep apnea. And for many patients, you see, they get off the small dose of medication that they were on. So that's where they are the sole contributors to the particular disease. But often they are co-contributors. There may be other reasons, and as was also mentioned by Dr. Murli, he mentioned about the kidney disease. There can be multifactorial reasons. But what I would suggest is that whenever there is sleep apnea and there is a comorbidity, and we suspect the comorbidity is linked to sleep apnea, we must not, we have to diagnose and treat the sleep apnea for more than the kidney reason. And I think if you treat that, you just need to follow it up, and that might lead often to pruning of medications and improvement in parameters. Next question is, we discussed a lot about diabetes, hypertension, a lot of CVA. Yes, that patient is having acute CVA with severe sleep apnea. Will CPAP increase aspiration? Well, you really need to see, protection of the airway is extremely important. At the same time, hypoxia, treatment of the nocturnal hypoxemia is also important. So if you are suspecting that, I think again you need a multi-specialty involvement. That's what we do. We have a speech therapist who's roped in to evaluate the swallowing, etc. We have the neurologist who's involved, and we also have our intensivist who's involved. And these individuals, when you think that there may be a risk of aspiration or acute CVA being managed, I think that needs to be managed in a multi-specialty manner. But whenever feasible, we must give it. As sleep apnea and the neurology can be a talk by itself. But in most of the cases, if there is an episode which has happened in an individual with sleep apnea, if you don't treat it, the chance of the second episode for the stroke is higher. Even for arrhythmias, it is higher. Next is, maybe I can, who wants to take this question? Can OSA patients take melatonin tablets, or is it contraindicated? Yeah, who wants to take this? Dr. Aruna, you want to take this?
Yes.
Or yeah?
Yes, sir. So, we generally don't recommend melatonin. Of course, melatonin is now available as an over-the-counter medication, and many patients, even without a doctor's prescription, use melatonin for insomnia, and without diagnosing the type of insomnia, and just over-the-counter. But in OSA, as such, we don't recommend melatonin because we have to find out what is the reason for you recommending melatonin, because it's to induce sleep. And generally, these patients, only the women who have the atypical symptoms, who have insomnia, so they are the subgroup probably who have these symptoms of insomnia. But generally in OSA, we don't recommend melatonin. We try to find out the grade of AHA, the data and the symptoms, and then address whether we have to use PAP or non-PAP treatments or lifestyle.
Perfect. And I think, yes, and Murli, as I go ahead, Murli already, has typed in. He's very good. Murli, you're very good at typing answers. You've done an amazing thing. You've answered a lot of questions here. Thank you so much for that. It just allows me to scroll down quicker and quicker. Amazing. So again, there's a very I think you've also mentioned about there's a point that untreated OSA is one of the cause of refractory seizures, and any patients who has seizures requires multiple anti-epileptics without any other cause. Kindly rule out sleep apnea. And Dr. Jayakumar, thank you for raising this point. I think it's an excellent point. Yeah. The next question is. Then next questions are what is almost we are coming towards the end of the question here. The one question is, a regular CPAP versus auto CPAP, which is better for patients with OSA with heart failure. I think if you look at all the trials, they say you do a CPAP titration and put the patients on a fixed pressure, and I think that works very well. But eventually, the point is, if you ever see sleep apnea with heart failure, you just need to get them onto a CPAP therapy. Okay. Yeah. Any other comments on that, or that's enough? Yeah. You agree on that? Yeah.
Perfect. Yeah. Absolutely.
Perfect. Yeah. Should we screen drivers, security persons, shift workers? Yes, we already discussed that. I think drivers need to be screened for that matter. Not only professional drivers, but I think anybody who's obese and driving needs to be aware about the possibility and the risks of sleep apnea. Okay, yeah, we discussed about titration. What are the and yeah, I think we are almost there. Sedatives are contraindicated. Yeah, that's an interesting question. Since sedatives are contraindicated in OSA, if a patient with OSA psychiatric disorders come, how to tackle this patient? Murli, that was your first patient. How would you take this?
Yeah, so if they need a sedative, you give the sedative as long as they're using the CPAP and they can protect the airway. So you need to ensure that their airway can be protected, as you just mentioned. And as long as you can do that, even if they use a sedative, and the sedative is important to help them for their psychiatric issue, not for the sleep issue, then you can use it along with CPAP. But you've got to be cautious, you've got to monitor, you've got to ensure that they can protect their airway.
That's perfect. That's great. I think I think we are still going to take a few. I'm going to scroll and see a few more questions. But I think this is an amazing initiative by the ICS, Dr. Sarmah, Raja, Amita. Amazing effort from your side. At this given point, we still have 1,979 participants, and we've got more than 160 questions. My apologies if I'm not able to take everybody's name before the question. A lot of these questions are answered in the panel discussion, and then I'm combining. If there are 2 or 3 common questions, we're combining them into one. Yeah. So thanks a lot for this. Now. There's a question from Madam Reddy from Andhra Pradesh. Tirupati, they say, OSA patient with sputum positive TB. What advice would you give about using the CPAP for patient and to the persons sharing the room? Who would like to take this? Yeah, anyone?
Yeah, the patient can continue with the CPAP, and setting of the room should be avoided because during the CPAP there is a aerosolization may be occurred. So that isolation is required, but patient can continue because the device will be is a personal device. He is only using it, so there is no harm in using CPAP.
What I would also suggest, therefore, is every day you'll have to clean the mask and the tubing very frequently because, you can leave behind AFB on that. It'll probably dry up fairly soon, but cleaning is important. You don't want it to spread. And of course, the exhaled air, we found this as a problem during COVID-19, that when you put patients on BiPAP or CPAP, you got a lot of the exhaled air coming out, which we thought may have active virus in it. So you had to take precautions when we had patients on CPAP or BiPAP during COVID-19. And the ICS came out with some guidelines, at that time. So that's just the addition to what Dr. Kripesh said.
So I think amazing. I think that's such an important question which Madam Reddy has picked up. Now there's one more question coming from Dr. Anil Upadhyay from Lucknow. How long we can wait for CPAP if indicated? Is it good to start? So that 2 questions. So who would like to answer this? Can we wait once there's sleep apnea? How long can we wait for CPAP to be started? Aakanksha, you take that or anyone? Yes.
I think we have stressed enough today that once you've diagnosed, once you have a patient with the evident symptoms, waiting is something which is not at all recommended. The complications, the other things associated. So I don't think there is a wait. I think it's more of an acceptance and understanding and educating the patient about the consequences of delaying treatment or not taking CPAP rather than waiting and seeing, because once you've diagnosed it, I don't think it is recommended to wait. It should be started as soon as possible. What this would really require would be educating and making the patient understand, because sometimes we see that the acceptance to that positive pressure therapy, that tight mask doesn't come. We have devices, we have different masks available. So as per the patient adherence, whatever it takes for him to accept the therapy is what should be actually focused upon rather than delaying the initiation of therapy.
So thanks a lot. Dr. Anil has also a second question. Is it good to start CPAP in adolescent as first line? Kripesh, would you like to take that, please? is it good to start a CPAP in adolescence as first line?
Yeah, in adolescent, basically, before the CPAP, most of this in adolescent, there may be obesity is one of the major factor in OSA in adolescent. So in that case, before starting the CPAP, it is very important to go for a lifestyle modification and weight reduction. Because if the severity of OSA is severe, then we can right away start with the CPAP and lifestyle modification. But in case of mild to moderate, it is better to start with the lifestyle modification and monitoring the patient.
Perfect, perfect. So I think we've covered dominantly a large number of questions. My apologies if we have not been able to take all the questions. There are certain questions which are related more to the treatment of sleep apnea, and I think these modules are going to continue. So what we are going to do is that some of the treatment related questions which have not been taken up will definitely be taken up during the subsequent modules. So I think it's been an amazing learning session. Just didn't realize that we spent more than almost 2.5 hours discussing about sleep apnea in such a detailed manner. So thank you thank you Indian Chest Society for organizing this certification course. Again, once a very big thank you to Dr. Amita Nene, Dr. Samaria, and Dr. Rajadhar, who have been instrumental altogether in getting this organized. And my special thanks to my dear friend Murli Mohan, also to Dr. Girija, Dr. Aruna, Dr. Kripesh, and Dr. Aakanksha. It's been an immense few hours of learning for me. Thank you very much.
Thank you.
Thank you, sir.
Thank you.
Thank you.
Thanks a lot. Thanks, everyone.
Yeah.
And a special mention to our moderator, Dr. Prashant Chhajed. Brilliant job.
Yes, sir.
Thanks a lot. Thank you so much. Yeah. Lovely to see you, all of you. And should I also, does the web admin want to say any comments, or we sign off? Yeah, we sign off. Hitesh, any comments from your side?
No.
Perfect. So
No,
thank you very much. Thank you. Okay. Bye-bye. Good night.
Good night.
Thank you. Good night, everyone.
Thank you
Good
so
night.
much, sir.
Good night.
Thank you, ma'am. Thank you so much.